Afternoon, everyone. I'd like to call the meeting of the Rutherford County Benefits and Insurance Committee meeting to order here on this Thursday, December the 16th. Before we get started, if everyone for today, let's make sure that we are speaking into our mics. There's a little audio trouble the last time on some of the sections of the meeting, so let's try to be mindful of speaking into our microphones so that everybody can hear. All right, the first item on the agenda will be Ms. Thompson doing a roll call, please.
Preble Acton. Here. Rhonda Allen.
Here.
Dr. Andrea Anthony. Here. Doug Bodery. Here. Amber Brown.
Here.
Shay Crowell. Holly Deering. Here. Brian Gaither. Here. Lois Miller. Alan McAdoo. Jeff Phillips.
Here.
Shantae Sherrill. Here. Eric Tutobeni.
All right. Okay, let's get this started. The first item on our agenda is approval for the minutes of our November the 18th meeting. I'll take a motion on that, please.
Move to approve as presented.
All right, motion. Do I have a second?
Second.
Have a motion and a second to approve the minutes that were sent out to us. All those in favor say aye. Aye. All opposed? Motion passes. All right, I'd like to call on Mr. Jeff Phillips, please.
Thank you, Madam Chairman. In the interest of conserving time, it appears to be a long agenda today. I move that we dispense with the reading of items number 2, financials, and number 3, workers' comp stats, and that those reports be adopted as presented.
All right, now I have a motion. Do I have a second? Second. A second from Ms. Shantae. All right, this is dealing with financial, so let's do a roll call vote, please, Ms. Thompson.
Acton.
Yes.
Rhonda Allen.
Yes.
Dr. Andrea Anthony.
Yes.
Doug Bodery. Yes. Amber Brown.
Yes.
Shay Crowell. Holly Deering.
Yes.
Brian Gaither.
Yes.
Jeff Phillips.
Yes.
Shantae Sherrill.
All right, thank you. Now, under item 3, we'd like to call on Mr. Dan Good to please come forward, please. Sir? That was item 3.
Okay.
His report was in that.
Okay.
So, as is kind of noted on mine, Mr. Dan has been here for a few years with us, and we'll get Mr. Elam to kind of go through that. But I want to personally thank Dan for everything that you've done for the county and everything. And if anybody wants to know, tomorrow's his last day. He's going to get to go home and enjoy retirement. Thank you. Thank you. All right, Mr. Ed.
Mr. Chairman, yes, I'd also like to thank Mr. Good. I've been here for 2.5 years. I know that Dan has been the type of person that, of integrity. He's worked hard. He cares tremendously about the employees and keeps their interest in mind in any decision that he has to make. And I'm very appreciative of the time that we've had. He's a good friend, not only to the people in the office, but everybody that has to deal with him on a regular basis.
Right. Mr. Dan, we appreciate it. You would like to address?
I'd just like to say thank you to the management staff of the county and to every county employee. This job is not a job that one man can do. It takes the efforts of everyone in the county, every employee, and even the residents of the county. And if you think one person can make a difference in this job, they cannot do it without the support. And I know Susan's going to be taking it, and I will hope and pray that you all will give her the support that you've given me. And I want to thank you all. Thank you very much.
Thank you, Dan. I appreciate that. The next item is the wellness update, and if there's not any objection, what's the wishes of the committee on approving this as presented in our reporting? Motion for approving this. Do I have a second? And a second. All those in favor, say aye.
Aye.
And all those opposed. Motion passes. Thank you. All right. Now we'll call on Miss Amber O'Neill to bring us a MedPoint report. Miss O'Neill, if you'll come up front.
And Madam Chairman, I have also asked her to give a abbreviated version of this report, but if you have any questions on what she doesn't cover, just, feel free to ask.
So if you'll look at page 3 on your report, we saw 882 visits in November. 706 of those were unique members seen. Of that, 395 were seen at the New Salem location, 298 at the Stewart's Creek location, and 189 were seen at the Walter Hill location. And then on page 8 for our in-person versus virtual appointments, in November we saw 126 virtual appointments and then 756 in-person appointments. That meant that about 16.5% were seen virtually. Of those virtual appointments, about 32.5% of them were seen due to illness, and the rest were seen due to choice. Since we opened our doors as the Ascension clinics, we have seen 2,271 visits virtually, or about 18.5% of our visits, and 10,011 visits in person for a total of 12,283 total visits. On page 9 for our referrals, you'll see that we did a total of 81 referrals in the month of November. Of those, 11 went to the dietitian, 10 to gastroenterology, 8 to physical therapy, 7 to orthopedic surgery, and 5 each to otolaryngology and endocrinology. I did pull some stats because last month you guys had asked about the dietitian referrals. So just to give you a little bit of follow-up on that question from last month. So we have done 277 dietitian referrals in the last 12 months. Of those, we have seen 173 people. So it's about 62.5% have followed up with those visits. Of those, 84 have gotten their initial visit but have not yet been seen for a follow-up. It doesn't mean that they won't be, but they have not yet been seen for a follow-up. And 89 have seen both an initial visit and follow-up visits. And then on page 11, in November, we had 706 total unique members for a total operating cost of $151,249.98 for a PEPM of $24. And that concludes my report for the month of November.
All right, thank you, Miss Amber. Are there any questions concerning this report or for Miss Amber? All right, seeing none, do we? Okay, don't need a motion. All right, thank you, Miss Amber. All right, now I will go with Mr. Elam on item number 6 about a new voting member.
Yes, I wanted to bring to the committee's attention that Preble Acton this will be her last meeting, and just wanted to thank her for her commitment to this committee and what you've done for the insurance and benefits. You've been a very nice asset, and very, I appreciate your input that you've given me from time to time. And that position is a position that is appointed by the sheriff. So she's turned in a resignation, and we have received the sheriff's appointment is Steve Spence, who is sitting beside Preble, and he's about to learn a lot of stuff fast. So.
All right, and thank you for that. And Ms. Preble, we appreciate your time served, and enjoy your retirement from this committee. And Mr. Spence, welcome aboard. Okay, well, happy retirement. And we do appreciate it. And okay, item number 7, we'll be calling on Mr. Paul Huffman to do our Cigna Medicare Advantage plan.
All right, Good afternoon. As you recall from last month, we gave you kind of a teaser and a quick overview of our Medicare Advantage PPO solution for your Medicare retirees. And as promised and as was requested, we wanted to give you a little bit more thorough discussion on that and also fine-tune some of our pricing for 1/1/2023. And so I've invited our Medicare Regional Sales Director. This is Jen Cuttaback, and she flew in last night to come here. She is the one who's responsible, that I work with, or responsible for putting together the actual proposal for 1/1/2023, and she's the expert on our Medicare Advantage PPO. So I'll turn it over to Jen, and she'll walk through a few slides that we have.
Thank you all for your time this afternoon. Just a few slides to walk through, just to, I think, further ground you all in Medicare Advantage. I listened to last month's meeting. I heard the inquiries and the questions that came up. So I tried to pull in a few slides that can give you more information around the group Medicare Advantage coverage. So with that, the last month's meeting, Paul talked about Part C for Medicare, really being the medical portion of the Medicare Advantage coverage, with the Part D being the drug coverage. And so our proposal is that bundled Medicare Advantage medical plus pharmacy for your Medicare retirees and eligible spouses. And I thought that this picture just gave you all a view of Part C really is that Part A and Part B coupled together. So your retirees will continue to pay for their Part B Medicare premium, and under a Medicare Advantage plan, they would then have a premium for that Part C and D, which is all-encompassing of Medicare. One payer. So today's plan is Medicare pays primary, either Medicare Part A or Part B, and then your plan pays as secondary. Under Medicare Advantage, it switches to that Part C and D, which is one payer. So Cigna takes on the liability and the risk for the claim payment. There is no submission for claims to Medicare to pay as primary. We are primary, secondary payer on your behalf. So I just want to get that out there, and certainly as questions come up, please let me know. The next slide, please. Paul walked through this slide with you all last month as well, and I just wanted to reiterate some of the key pieces of information here. So one ID card, one customer service organization and call center for your retirees really allows individuals to get to the right place, the right time for help. And that is different than today's world, where your retirees are going one place for medical inquiries and another place for pharmacy inquiries. So this is all housed in one. The wellness incentives on the plan differ from what's available today. So part of the benefits of a Medicare Advantage plan is it really takes the Medicare program, and adds in a whole bunch of bells and whistles for programs and services that are eligible, that the retirees become eligible for, and that assist with total care management. So Medicare doesn't do care management or care coordination as a rule. And that's why Medicare Advantage plans have become very popular for both individuals as well as for employers to offer to their retirees, because they do offer wellness incentives to individuals. So there's a focus on going to the doctor, having your annual exam, going for follow-ups. They have a Silver and fitness benefit, and it's not just going to gyms. There are other benefits that are bundled into that fitness benefit as well. There are monetary incentives for having certain exams. So having an annual wellness exam, having certain exams such as when it's time to have a colonoscopy, having your colonoscopy, for women having their mammogram. Really the focus is on keeping the individual as healthy as possible, and finding out if there is a need for care, and finding that sooner rather than later, to be able to manage the total health and well-being of that retiree necessary, as well as the cost of the program. So that is, in a nutshell, the Medicare Advantage PPO on the network side of things. So we are able to offer a Medicare Advantage plan to all of your retirees, regardless of where in the United States they live, because the majority of your retirees live in and around the service area, which allows us to offer to folks outside of Greater Tennessee where we may not have a network. They can go to any doctor who is in our network, as well as they can go to a doctor outside of our network who is willing to bill our plan. And that benefit is different. So for group business, our in and out of network benefit is the same. So there's no harm in going out of network. You're not going to pay a higher cost out of pocket to go out of network. That's different than plans sold on the individual market, or what we call street plans. Street plans typically have a leaner out-of-network benefit, so people are paying more when they go out-of-network for coverage. So I just want you all to understand that this group plan, there is no harm going out of network to the individual, and the cost is the same. Yes?
Just clarifying for me, a street advantage versus this advantage. Are you saying that this plan is not available?
So when I say a street plan or an individual plan, I'm talking about the plans that were just open enrollment through the marketplace, where individuals do not have employer-sponsored coverage. Your plan is an employer-sponsored coverage. It is not a street plan.
Designed specifically
this
through our whole population.
Yes.
Right.
So you have a highly customized plan that mirrors, so the medical plan closely matches the current medical benefits that are offered to your retirees. And the pharmacy benefit is exactly the same as what your retirees have in place today. So there's no change on that. It's really just the medical piece.
Excuse me just a moment. While you just spoke to the pharmacy available to our retirees, if we decide to go with this Cigna Medicare Advantage, the few retirees that are already retired now that have to go find their pharmacy somewhere else, because we have a few, they will actually be able to, if we switch and put all the retirees, they will actually, it would be an added benefit to them, because they would be able to pick up the pharmacy that they had to go out and get otherwise. So just an FYI, I did pick up on that.
Thank you. Yes, and I think that's an important point, because, again, the pharmacy plan that your retirees have access to and are enrolled in today is a group Part D plan, but it is customized and it does have richer benefits because it's on the group side versus the individual side.
Yes, Ms. Steve.
So our retirees that already have the pharmacy in their plan, will they be able to participate in this as well, or will there be a disruption of service for them, or will this be a better service for them?
So what would happen if the county moves into a Medicare Advantage PPO plan, the individuals would come out of the OAP medical plan and the standalone pharmacy plan and go into a combined Medicare Advantage plan with the same drug coverage. There's no disruption into the copay structure is the same, the formulary drug list is the same, so there wouldn't be disruption moving to a separate plan. They would just be moving over to a bundled Medicare Advantage plan.
So on the slide where you were talking about, pull it back up. to make sure. I want to make sure that I heard you right. So on this side where you've got A, B, C, D, which is all the plans. So currently, Part A, the government, Medicare, whatever, pays on behalf of the employee. Part B is because it's hospitalization. Part B is something that the employee currently has to pay Social Security. If I heard you correct, you're saying if we went with this plan, the employee would no longer have to pay Part B to Social Security. It would all be wrapped into this PPO. Did I hear you wrong?
No, that is not correct. The individual will continue to pay his or her Part B premium.
So this is just a supplemental for C and D?
This is, yes. Yes.
Which, if I may, which basically, Sonia, is what she is presenting would cover what our almost 500 retirees already have now. Instead of being self-funded with us, they would go on this Medicare Advantage, and it would help a few that actually don't have to pay the extra pharmacy somewhere else, and it would be all wrapped up in one. So
that's what I thought, but I thought that I heard, so I thought, well, if I heard it, somebody else might have heard it that way too, that this would have taken the place of B because C is adding A and B together, so that's why, but it's A and B as a supplement. You still have to have your primary, and this is a supplement.
yes,
Right.
yeah.
My question was on the A and B, because you said one card. So going into the hospital, would somebody say, on the Advantage say, here's my card, my plan? Oh, it felt like it was on. Okay. When somebody goes to the hospital, they have their one card. Let's say I'm going to the hospital. That's something that's covered under A. Is it the hospital applying to Medicare, or are they applying through this Advantage plan, and the Advantage plan applies to the feds?
So I understand. So 2 scenarios. Let me just tell. So today's retiree has a Medicare red, white, and blue card. So that's their Medicare A and B card. They have a Cigna OAP medical card, and they have a Cigna Medicare Part D RX card. Those are their 3 cards. So if they go into the doctor's office, they're going to give the Medicare, red, white, and blue Medicare, as well as their OAP medical card. In this new plan, individuals still have their Medicare red, white, and blue card, but that card no longer needs to be shown or used. It is a put it in the drawer. That's what it's going to look like. Put your Medicare red, white, and blue card in the drawer somewhere, just so you have it safe. But you are going to have one ID card, and it is going to be a combined medical and pharmacy card, so it will have all sorts of information on. But you go to the hospital, you are going to show one ID card, the Cigna True Choice Medicare Advantage ID card. You will go to the pharmacy to fill a medication. You are going to walk in and show that one ID card. It will have the pharmacy bin numbers and all sorts of things that your local pharmacy needs to run the script. So I hope that helps.
So if I understood Paul correctly, last month there was a lot of discussion about the possibility of us moving to the state plan for group health. And so you said that this was not an option if we make that choice. Is that correct?
I may have answered your question in a way that may not have answered your question. So the state does not offer this plan. If your question is if the county or the school board moves to the state, is this quote still available for that group through the county? Yes, it is.
Okay. So then my follow-up to that is are you able to bid this to us because we're currently using Cigna as our third-party administrator, and so if we made a change in third-party administrators, does that mean this plan goes away, or are we still able to offer it?
So, a couple of things there. So the reason you are able to look at this right now, look at it from me, is because we're contracted together. We have an arrangement, so you don't have to go through procurement. It's just another service that we provide to you. If you were to put it in place and have it written with us, and you were to change your third-party administrator, you could still keep this.
Would that affect the rates?
No. The rates would be based on the enrollment in the Medicare Advantage plan itself. So as long as that doesn't change, the rates are going to stay the same.
All right. Speaking of the rates, moving on, just wanted to talk with you because last month Paul was able to share the rates that we had run for 2022. So what you have up in front of you are the rates for several plan options for plan year 2023. They are noted as being illustrative, and the reason they are illustrative is because every year the federal government, CMS, rolls out its funding arrangement for the following Medicare Advantage cycle. So beginning in February, there is an early call letter, and then in April, the government releases their funding for group Medicare and individual Medicare Advantage plans, which means that until we get that information, we cannot solidify our pricing. We just need to make sure that the government subsidies are coming in as we've expected and as we've planned for them. So this is illustrative, but I will tell you that I've been doing this for, I've been on the Medicare team since 2004, and I do not see rates coming off and shifting much from what we do on an illustrative basis. So I can share that with you here today. The plan costs on the examples or on the document you're looking at still show the $606 as the total cost of your Medicare retiree plan on a per member per month basis. Now that 606 is all in, so it's not the county's portion or the retiree's portion. That is the total cost of the plan. So as you look across, the next column, which is highlighted as Medicare Advantage, the PPO Custom Medical and RX, this plan is pricing in just over $400 less a month per individual. So it is cutting the cost significantly. And again, that is the total cost for the plan, not the portion paid for by the employer or the retiree. That plan is a little different than what was priced out and shared with you last month, because we went back and looked at the plan design and truing up some of the benefits. So your retirees have a very rich medical plan in place today. It basically pays for everything after Medicare pays. So we went in and updated the plan design, which you all were sent a copy of an updated medical plan that basically shares a $0 copay or co-insurance that the retiree is responsible for paying. There are a few benefits that have a small cost share, but the majority of the benefits are $0. The data on this, just so you all understand, the two scenarios on the bottom of this rate sheet show the first scenario is the savings that would be achieved if the Medicare Advantage plan were to be put into place, replacing today's OAP and Part D plan. The second savings example is an assumption if you were to offer it on in addition to the plan today, and only 30% enrolled. So just two savings examples for you all to see. But there is significant savings to be achieved with Medicare Advantage PPO for your retiree population.
Sorry, I have another question. So when you said earlier that the rates are based on the 2022 enrollments, just, for the purposes of this, if their enrollments were to change, so if you're looking at our current retiree enrollments or our anticipated retiree or our total employee, total enrollments in the plan, when you say that, what enrollments are you looking at?
We are looking at those who are enrolled in the plan today. Medicare, your Medicare enrollment.
Plan. Okay, that's what I'm wanting to know. Okay.
Yes. All right, next slide. I think that as last month's meeting, one of the questions that came up was what's the catch? Why are you showing me so many such savings for this plan? And you know, it's really thinking about this as a completely different type of plan than it is offered to your retirees. So I talked a little bit earlier around the aspect of wellness, and there's care management on this plan. So we are looking at providing retirees in Medicare Advantage plans access to preventive care to identify any ongoing care that needs to be managed. We have clinical resources and nurses that engage with retirees and their family members who are assisting them. The plan has transition of care benefits for retirees. We can get individuals from the hospital back to home, do home visits. We have a program where individuals can receive meals after being hospitalized so that they can take care of themselves and they don't have to worry about shopping or cooking. Family folks seem to love that. The plan has a hearing benefit on it, a vision benefit on it, and some other bells and whistles on it, such as, you know, fitness benefits that folks do not have access to today. And again, I just want to reiterate that there is no difference in the pharmacy piece, which almost, when I've done client implementations and whatnot, the pharmacy disruption is always the biggest issue. Don't mess with people's medications and their formularies and the drugs list. That is a complete, it just slides through. It's a replacement. There's no change to that pharmacy plan.
I'm sorry.
That's okay.
So is this, if you said earlier, you said this plan, well, an option that we have is to keep it the same services and medications and things that we currently have with our current program. What if the county decided they wanted to change a formula? Do we have control over that, or is it just set once you establish it? Am I asking in a way that you understand what I'm saying?
Yes, I understand. So this is a customized plan to closely match what the county has in place today. By no means does that mean year over year. You cannot tweak the plan to accommodate what you would like to do. So if you would like to, I'm just trying to think, because again, it is a very rich medical plan. It's something about, you know, in future years, are you allowed to add copays to the plan and have a little bit more cost share for retirees? So they go to a primary care visit and they pay $5 out of pocket. If they go to a specialist, they pay $10 out of pocket. Those things can be done. The drug plan, the coinsurance and the copays, and some of the buy-up medications, those can be looked at each year upon renewal on the group plan.
Can you explain to us on the part about vision, is that full vision coverage, or would someone still need a carved out vision plan? Is that going to encompass the whole thing that our current policy would replace it?
That's a great question. So on the vision plan, which is part of that document that was sent, Medicare Advantage plans standardly offer some form of a vision benefit and a hearing benefit. I know you all have a vision plan, and we do have other clients that offer Medicare Advantage as well as they continue to offer their vision plan alongside it. So it's almost as if the individual has a double dip and can use, you know, maybe one benefit if they need lenses and another benefit if they need frames. So the benefit for the Medicare Advantage plan is a $200 annual allowance for eyewear. So it's a little different than what you all have on your vision plan. And again, we are happy to customize, and we can manipulate that and tweak it if you'd like. Other questions?
Anybody have any other questions?
I have one last question, Ms. Chairman.
Alan?
So if the school system decides that they want to go with the state plan, we can still offer this to their retirees?
Yes, we've discussed that. That is a possibility, like I said, if the county still, well, it all depends on how many of the school retirees you get to stay with this plan. So we're assuming that this quote assumes at least 70% of what we've assumed that are currently enrolled, which is almost 600 total members, employees plus spouses, I believe. As long as we get 70% of that group, then yes, it could be offered. It would be the only thing that would be offered to that group from this side of the house. Yeah.
Anybody got
So
any
if
more
the-
questions? Go ahead, Ms. Sonia.
So if the state, if the Board of Ed went to the state and it was a requirement that their active employees and their retirees went with it, then the assumptions for this would change?
Correct. If the requirements were that the retirees had to go to the state, then this is null and void and no one would enroll in it. Correct.
Right. I have a question on your slide with the dollars there. I know you said this was total pay, and I guess want to reiterate this 204, 177, 76, or 220, 69. That's the, based on this and all these assumptions, that's the worst case scenario. That's the most our retiree would have to pay out at that time. This does not take into account our 50% share that the county departments and/or funds match. This is, and I know, I just thought about this. Say the 22069. My mother's on it and my dad too. So is that 22069 for mom and 22069 for dad? Is that right by doing the PMPY?
Yes, that is
Yes.
I'll call it the individual rate.
Okay.
Yes.
Well, just for information of this committee, if you did, just for round numbers, $440, that's still cheaper. That would say this was mom and dad's total out of pocket and the county didn't put anything as being a retiree, their 50% or whatever. This is still less than mom is paying right now for her and dad's coverage on our county retirees. So just to let y'all know, that's pretty good. And I have went over all these numbers and had major questions. And just to be very honest, I've looked to see if I could find a problem with it. And everything that I've looked through and having conversations with different ones and even Mr. Paul, this is everything that I've seen, researched, and outside of them, what they are presenting to us is pretty smart and pretty, I say, safe to offer our retirees that have worked to have the benefits of being a retiree. And I looked through my 25 employees that are on the retiree plan. I had a gentleman that started in 53, retired in 82. His widow is still on the plan. I've got folks that have been retired, one retired 2 weeks ago, and some that have been retired since 82 that have been on our county retirees insurance. So just to let you know, that's ages and years of service that our county employees give to Rutherford County to be able to have some type of retiree benefit. So when you can look at this kind of number and say, wow, that's still less, even if the county backed out and said, we're not paying for any of it. Of course, I hope the county don't do that, but these are real good numbers to look at. So any other questions?
Can I ask a quick question? Over the last couple of years, what has been your rate increase?
On the Medicare Advantage plan, so Medicare Advantage, our first plan was Williamson County in 2020, and on the Medicare Advantage PPO side. And we have seen, so we're new to the market several years. I don't have 7 years of this, but we are single digit, and it really, the The big piece is going to be on the drug utilization side. What's that drug utilization, and how many individuals do you have taking specialty medications? That can kind of tip that a little bit, so it could be a 7-8% versus a 3 to 5% on the increased side. I've seen some flat.
All right, Commissioner Allen.
What's the time frame? When do we need to make a decision by?
Well, I mean, for us, we need, 120 days. So we are looking, into next summer, early fall for a decision. But I believe that other decisions need to be made in advance of that. So we are this is not a February, March decision that has to be made. Best case scenario would be we know in July and August, because then we like to do some outreach and engagement with your retirees to help educate them and talk about, come to meetings, learn about the plan, here's who to contact, and so forth. A little bit more of a high touch.
Okay, Ms. Sonia.
So on your page that's up here right now, the savings that we're seeing is the savings to the employee, or is that the total savings for the total?
That is the total savings to the total. So if you assume that Rutherford County is paying 50%, I'm just using.
So then it would be a 1.5
It would be half
million.
of that. So, the savings that's up there is savings that's going to be achieved by both the county as well as your Medicare retirees.
But because the premium is going to be less than it is now, if the county said for whatever reason that they were not going to fund a portion of it, then that would be the total savings to the county, and the employee would still incur a savings because their premiums would go down, correct?
Correct.
Okay, so like if the premium is currently $606 and we're doing 50/50, it's $303, the employee would incur a $100 savings, but the county would incur a $500 savings about.
Yes. So
Am I saying that right? Okay.
The individual is still reaping the benefit of a savings, if that changes.
And this was information and looking forward to trying to have, just for the information of the committee, something that we can go forward on. We'll be looking at making decisions on some presentation that we'll have later on this afternoon for decisions in January, if this, because this will affect our budgets that they're going to start talking about, and the monies for it. So this would not even be an implementation for us until January 1st, 2023. So this would. We need to make a decision sooner than later based on budget numbers and which way the direction of the county and/or BOE or all of us together need to go in. So the sooner this is made, this is one thing that we can check off our list. And we have time to start the implementation and seeing, but we get the budgetary items out of the way and put something in motion that would be a good plan, I feel personally, for our retirees. So that's a deadline as for such is we have budget to start setting, and I think Ms. Lisa start handing out those forms in January. So the sooner that we can start getting numbers and make at least one decision, we can go forward with that. Any other questions?
Thank you for your time.
Thank you. All right, y'all have heard the discussion and what, okay. We've heard the discussion, and do we have any more discussions or questions? Do we have a motion to go to or from? What's the will of our committee at this time? All right. Are we going to just, do we want to, yes, Ms. Allen?
I would really just like us to take it under advisement, move through some other presentations, digest a little more information that's going to be coming at us, and then if we have time, which it sounds like we do, I think we just take this material under advisement for now.
Okay. All right. Do we need a second on that? No, okay, all right, well, we will put this aside and come back and look at this. So that gets us down to our next item of calling on Miss Jessica Sutherland to do a state plan presentation for us.
Thank you, and thank you for having us today. We're just grateful for the opportunity to be in front of you all and walk you through this a little bit more so you can make the best guided, most well-informed decision possible for your people. So our local government and local education plans have a lot of similarities, right? The plan itself, the coverage is the same. The biggest varying differences are the rates, the premiums, of course. There's some differences in the eligibility requirements for retirees, and then what is classified as an employee, like the employee definitions found in our plan documents. So in order to avoid confusion, we're going to present this presentation for you guys today, and then when we get to the rates, we'll separate it out so you can see both. And then when we get to the end, the retiree eligibility will be different. And then, of course, when we open it up for questions, we'll try to piece those out to where we do all the local ed questions together and then all the local gov questions together. So that way everybody is clear and it's transparent and there's as least amount of confusion as possible. And I myself will try to not be confused as well. So we'll go ahead and get started. There we go. So our objective today is just to learn about local government health plans specifically, but also, your local ed. It's congruent in this fashion, and then compare the plans to the current county plans, and then explain our plans for active and retirees, and then, of course, Q&A. So what we do at Benefits Administration is we actually administer the state of Tennessee sponsored insurance benefits for over 286,000 state, higher education, local ed, and local gov employees, dependents, and retirees. So we have a pretty large risk pool. Now, granted, the local education has their own risk pool. Local government has their own separate risk pool. We serve over 390 local government agencies across the state. And we serve 125 local education agencies and growing, right? So our local education pool has over 113,000 members. Of course, that number doesn't include their dependents or spouses. And then our local government has over 26,000 members. We are a self-funded plan, so the state plan assumes risk for all claims. We actually collect the premiums and then turn around and pay the claims ourselves. We only pay the insurance companies a small administrative fee to provide services and negotiate the best-in-class plans, best-in-class service. We're able to kind of go to the table with a huge buying power, right? Because our risk pool is so large, so we can design products with our carriers that are best for our members. And it's not something you just go and shop off the shelf and get whatever plans Blue Cross or Cigna or whatever the carrier may be is offering. We actually design our plans based on, what's best for the members, and we're able to kind of design a plan that can't be found anywhere else. And then the other piece of that is that we're able to hold them accountable for providing things like call centers and being available to our members and strict audits and different things because we have that big buying power and our larger risk pool. The other piece of this that's important to consider is all of the rebates and things like that. We take those and then reinvest those to keep the premium increases at bay and as low as possible. We actually put away 10%, right, in like a savings account to ensure, if we have a large claim or something like that, we're covered. But anything over that 10% we take and then reinvest, so that way the premiums don't skyrocket, right, year to year. Granted, there's increases, but we've been able to kind of negate some of that because the healthcare inflation rate was, say, for instance, at 6%. Well, the premiums did not increase by 6% because we were able to take those savings and that extra excess of funds and reinvest that to kind of level the playing field. The other piece is we're constantly innovating and researching ideas. We're partnering for new tests and things like that, and you'll hear about some of that as we move forward. So on the state plan, there's a choice of 4 products and price points. We have 3 different PPO plans and a local CDHP HSA plan. And all plans are offered, and all employees have to have the choice of all plans have to be offered, and they have to have the choice of whichever plan they desire. So you can see here just the differences in the premiums and versus the out-of-pocket costs. And then, of course, the HSA has the lowest premium, but it works a little differently. You don't have co-pays. You actually pay. You have to meet your deductible before the plan starts paying, and they pay a percentage, the co-insurance, as opposed to like $25 if they make a doctor's visit, depending on what plan they choose. There's also a choice of 4 networks. We have 2 narrow networks and 2 broad networks. The broad networks, the important thing to call out is that there is a surcharge for these networks. The narrow networks provide, the care, the doctors, and the hospitals at a lower negotiated rate and include most, but not all. Kind of the advantage of the broad network is it includes almost all providers and hospitals, but at a higher contracted rate. As far as dental is concerned, there's 2 options. There's a Cigna prepaid DHMO plan and a Delta Dental DPPO plan. And you can see the differences there in the premiums, and that's the same for both local ed and local gov. I will call out, just as we're getting into the voluntary options, local ed and local gov do have the option for dental and vision, but do not have to take dental and vision if they do decide to come on the active health group plan. Here's the comparison chart for the 2 plans that we offer. Of course, we will be sharing this presentation so you can take a look at it more closely. I know this is a lot on a little screen to look and compare line by line. But we also have it available for vision. You can see the rates here for the basic plan, employee only, $3.07, expanded plan, $5.56, and that's applicable for both local ed and local gov. There's 2 vision plans as well. One's a basic plan and one's an expanded plan. And we have the same type of chart too, where you can go line by line and compare the coverage. At the state, we have a dedicated call center, and we really pride ourselves on this because a lot of times, sometimes you guys know just in general with call centers, you call and wait on hold for forever and it's hard to get through to someone. We have an average response time of 2 minutes to answer members' calls, and we have over a 95% satisfaction rate. We really pride ourselves on this to where we're available to answer questions year-round. And we also, to my point earlier, we have call centers that we've held our vendor partners to be accountable for too, for our members to utilize as well. Some of the communication support we provide, we do monthly agency benefits coordinators conference calls, so that ABC is what we call it. Each agency has a designated ABC, and we do conference calls monthly and then weekly leading up to the annual enrollment period. We send out weekly ABC emails, and we have webinars and training. We also have a pretty large social media presence, a very robust website that has all kinds, a plethora of information and videos and everything that the members, retirees would need as far as, I mean, everything we've covered today, all the questions I was sent, all of that information is right there. We're very transparent on the website with everything someone would need to know. And then, of course, we provide enrollment guides and handbooks and directories and plan documents. And then, of course, we have a whole course for a new employee who is onboarding to help make it easy for them and consider all their plan options when coming onto the plan. Telehealth is another service that we offer. We have a medical telehealth, and we have some of the carrier-sponsored programs through Cigna and Blue Cross. We also have a behavioral health telehealth, virtual counseling sessions, and some other services that you can take advantage of that we'll get into right here. So we actually host the Here for Tennessee program that encompasses our EAP and behavioral health. You can get up to 5 EAP free counseling sessions. There are resources, apps, tools, support for anything you could possibly think of. If you're looking for a gym, or you're looking for a daycare, or you're looking for help in determining a second opinion of a diagnosis, or the best doctor, or any of those things, we have a ton of resources available to help. So here's a few ways that members can connect. The San Velo app is completely free to the members on the plan, as well as the Take Charge at Work. And the app is just really designed to help with stress, anxiety, depression. I mean, we've been through quite a bit, just everyone as a whole in the world with the pandemic and everything like that. So we have resources available that are just kind of extras of being a part of the plan. Here's some of the things I was mentioning earlier. It's things that you don't even think about, that pregnancy services or childbirth or family activities, even finding a camp for your child. There's just a lot of resources out there that are kind of extras of coming on to the state plan that are available to our members. And here's another just more in-depth explanation of what you would get as far as legal, mediation, and financial. As a part of the plan, you get a 30-minute phone or in-person consult at no cost to you for legal advice, mediation, and then financial, you get access to a money coach. These are just some of the perks that you would get as a covered member of our plan. Know Your Health is another piece of this. Strategies on finding a doctor, questions you may ask, on your visits, benefits of preventive care, understanding your EOBs. Some of those can look like foreign language when you get them in the mail, and a lot of times you get them and you're like, what is this? Or you don't understand, and they'll walk you through that piece. You can find and compare hospitals, costs, all of that. All these tools are right at your fingertips. There's also programs through Blue Cross Blue Shield. They'll help you find distinction centers and performance ratings and patient ratings and reviews if you want to see if you're in the market of comparing. Same thing with Cigna. They also provide some of the similar resources that are available to you. Medicare.gov and Choosing Wisely are some of our information that we provide our members on finding and receiving quality health care. And then, of course, our cost transparency tool. What exactly are we paying for when we are paying for it when it comes to health care? This is a great tool to do a cost estimator if you're just exploring, and it can help in the decision of which provider and which facility is best for you. And then the final thing I just wanted to call out as a perk is you would also be taking advantage of the state employee discounts. So everything we get as state employees, you would now be receiving through PerkSpot, and that encompasses, discounts on your cell phone bill, on Enterprise, on Dollywood tickets. There's all kinds of great things on there that, as a part of the state plan, the members would now be able to take advantage of. Okay, so we'll now get into the comparison of your current county plan, and this is actually the local government rates here. And so you can see, which of course we'll share this presentation because I know it's a lot of information on one slide, but the state premier plan most closely aligns with the county deductible plan. Our state standard PPO plan most closely aligns with the county copay plan. And then of course we compared our HSA plan to the county HSA plan, and you can see how they line up. Rutherford County local gov is at a level 2 premium rate based on the information that was sent over on the employees, the size and age of the agency. So these are actually the rates for your narrow and broad networks. So the narrow is just the normal networks, and then the broad rates would be the expanded networks. But you can see how they line up. And then on the following slide, this actuarial value was done for the local education plans. Now your Rutherford County plan, the value there will be the same consistently because it's the state plan that has the differing premium rates. But these are the actuarial value based on the local education. So what it does is it provides, you know, an apples to apples comparison, right, of the actual plan, and then the percentage itself is the percentage of total average cost for covered benefits that will be paid by the plan. So basically, what kind of value are you getting for what is offered? So you can see how it lines up with the county plan. The deductible plan was 87% versus our premier PPO, which was rated at a 90.5%. The one call out here on the HDHP plan, the value was assessed at 83.9% versus the state plan at 80%. The difference there must be taken into consideration the fact that Rutherford County contributes money towards the HSA account, and that was not considered in the state because we don't know what the county is going to contribute. So that contribution, $500 or $1,000, depending on if you're employee or family, that Rutherford County currently contributes was considered in that 83% value. So as far as local education goes, this is kind of the same comparison with the local education rates in it. And then this also has the values listed in a side-by-side comparison here. You can see the rates are just a little different. They vary from the local gov rates there. You guys will get this presentation as well, so you can see it. I know it's a lot to see on a screen. Okay, so the planned clinics, we know that you guys operate the 3 on-site clinics. If you were to come onto the state plan, these clinics can still operate. The difference is the members would just have their, as long as it's in network, that we verify that the clinic would be in network, then the members would have their convenience clinic copay. This map also shows the list of convenience clinics in Rutherford County, the options that the members would have, and depending on which plan they chose, it would be a different fee, depending on if they chose a premier PPO versus standard versus limited. But these clinics could still potentially operate if you wanted to keep them open. As far as hospitals in Rutherford County, Ascension St. Thomas is in all networks, but the TriStar Stonecrest is out of network in the narrow, but is in network in both of the broad networks. Okay, so we're going to move into retirees. This is going to be very high level overview of our retiree coverage. And like I said, this is another piece where it varies. So in the end, when we're asking questions, we'll do all of local ed questions and then all of local gov because it is different. And this is probably where the lines can get the most crossed, I feel like, because there's a lot of questions on combining service and if people move from a local gov to local ed. And we actually do have our retirement specialist on the line, and she's going to help us navigate this. But we'll get into local gov first.
Before we move to the retirees, can we ask a couple of questions on the active employees? Because there was a couple of questions I had. Would you mind doing that, or do we need to save them all to the end?
Well, we have either way is fine. We're fine with either way, but there are a couple things we wanted that we got ahead of time that we plan on addressing. So it may be covered. Your question may be.
Okay, well, the one that just popped up now, this comparison, I'm interested is why you did in your comparison for the county used our open access plus rates, but when you used your rates, you used the local plus rates, which are considerably less. So I'm wondering why you did that.
For local ed or local gov?
Local government and local ed. I looked at both presentations. So I was curious why you used the open access plus of our rates, which are higher because they can go anywhere, versus your local plus rates that you had on your sheets.
We broke it down by network, so it should be, you should have the narrow rate and the broad rate. Do you see that on yours?
I do. One's for open access plus and the other's for, so that's why I was curious. And what level are you putting Rutherford County in? Are we level 1, 2, or 3 when you're looking at the regions?
Level 2.
Level 2, okay.
What makes the distinction between level 1, 2, and 3? That's one question. Just the overall question, just out of curiosity, what's the thought process by having Blue Cross Blue Shield and Cigna instead of one? Third question is your comment of the Medicare clinics that they could still operate. And I'm assuming that you're, so you know what they say about assuming, that currently our Medicare clinics are funded by pretty much the premiums that you have listed, because they're not funded by the patient going there and a rate is going to some clinic. It's the county is funding it fully. So when you say if we go out back to the state, we would have to get, I mean, we would not be funding it anymore. It's not, currently it's a part of the rates, it's all in a big pool. But if we're taking all the rates and going to the state, there's not funding except the 1s and 2s and 3s that go to the thing, but I don't know how. I just can't see how that works. I can't see, if we all go to the state, how we will find somebody to fund it other than the county saying we're going to fund it, which becomes another cost on top of what we would be paying going to the state for premiums. Do you agree or disagree?
So first and foremost, the level of the premiums for local gov is determined based on the age and size of the agency. So Ed sent me a survey with the employees, the age and size, and we have a calculator that we put it in. Right, level 1, 2, or 3. The clinics, was there a question in between that? There was.
Just the curiosity of the states going to and say we're offering a Blue Cross
and
Shield
Cigna, yes.
And
well,
a Cigna.
I don't know, Teresa, if you have any more clarification, but really having both just gives our members more options. And we open it up and look at procurements with different carriers based on a contract schedule. And really just this gives members more options. They can choose Cigna or Blue.
But if I were doing a comparison, would I compare what our rates are with Cigna, which I'm assuming our Cigna group, to Cigna level 2 to be my apple to apple? Does your Cigna equal our Cigna?
I think I understand what you're asking. When we're comparing y'all's plan to our plan, our rates do not differ based on Cigna or Blue. The member can choose either one, and there's no price difference on our plan. Now, granted, our plans, exactly the coverage and all that is not exactly lined up because the state negotiates a plan that is unlike any other. So the best thing to compare apples to apples is that actuarial value that we talked about there. So Aon, which is actually who Rutherford County uses too to evaluate, we had them evaluate our plans versus your plans, and they assessed a value there, and that's probably the easiest way to compare.
Well, I guess if I'm an employee, just an employee who doesn't understand actuarial values, it's like, I just want to know what my doctors, my coverage, currently under Rutherford County's plan, what it covers, what it doesn't cover. Does it mirror the state's Cigna plan level 2, region 2, whatever? Is there a way that I can go in and say, can I assure my employee you got the same coverage, you're not going to see any difference, you're Cigna, you can go to Cigna, it's all going to be the same. Can I make that statement?
I mean, we have our comparison charts for what our coverage is to where an employee, to your point, they don't understand what 90% value is. They can look and see, okay, if I go get a preventive wellness check, I'm not going to pay a dime. And I know on my current Cigna, I don't have to pay a dime either. Per se, I don't know if that's the case or not. But if they go to see their primary care doctor and make a visit, I know I'm going to have to pay $25 if I choose this plan. So we have a chart that shows exactly what they have to pay and can break it down based on a primary care visit versus a specialty visit versus what their deductible is going to be on an employee versus spouse versus dependent line, what their out-of-pocket max is going to be. And yes, we can show that chart of all of our plans side by side so they can make the best decision and see exactly what they're going to have to pay if they make a visit or if they have an ER visit or something like that.
I mean, that's what I want in my hand to be able to say, does it cover, does it not cover?
Okay,
I just don't want anything to come back to say, oh, you didn't tell me that.
Yeah.
So, well, I didn't know to ask that.
Sure. We have those charts and we're happy to provide them. We have shown them at several board meetings, and I think they'll be posted on the website as well, and we'll send them when we send the presentations.
And the other one is just that contemplation of how in the world can our Medicare clinics continue as is if we are part of the state.
Sure. And so our perspective is we're just saying that we don't have any regulations. Whether or not the county wants to continue to fund them is up to the county. We're just saying that we are okay. We do not have any regulations on them continuing to function. It was our understanding that the claims were being billed through Cigna. Is that not the case? No. Okay.
When you look at what are our total costs in the county, we pay claims, we pay administrator, and we pay a base amount for our Medicare clinics. We pay the doctors, the facility, everything. It's outside claims and third-party administrators. So our rates include the cost of those functioning. So if we, as a party, said we're no longer going to have Medicare clinics, then that's I can't remember what, you probably know, that cost would come out of our rates, all right? That's what I'm saying. I don't see in my mind how, if we all go to the state, garner the better rates, have this other thing happening, or it's an add-on to the rates. I just don't see how we handle that part. Anyway, that's my questions.
The clinics are a pass-through. Our self-funded, help me if I'm saying that right.
Ghost billing. We do ghost billing.
Yeah. So I mean, Cigna knows what they went in for, and it's hanging out there, but it's no charge. It's like Ed said, it's a ghost billing, and it does come out of the premiums as we see our funding each month and look at. It's put out at the tail end of Ed's reports. This is what the clinic cost us this month. That added per employee per month to the fee. So that's why you would see, yes, there was Cigna, but it was passed through with no charge to it.
And the county employees that are on the HSA plan are having to pay a fee when they go to the clinics, is that correct?
Yes, that'll,
Okay.
yes, yes.
But not
Sick visit,
previously.
yes.
Not previously, now it will be with HSA.
Yes, and that's a starting 1/1. Yep. Okay, are there any other questions? And we'll try to, I do know that she has a list that we'd all compiled of questions, but let's go ahead and get into the retirees, and because I'm checking off the questions as we go too. So go ahead and we'll continue with this, and we'll come back to some questions.
Okay, perfect. So local gov retiree health coverage. So when the agency first joins, the agency has to select the opt-in or limited opt-in or opt-out offer for the retiree group health coverage. If one of the options is selected, if it's opt-in or limited opt-in, you can bring in any covered retirees and their spouses who are under the age of 65. And cover children under the age of 26 who are not Medicare eligible. And I did want to go through just the official opt-in difference versus the limited opt-in. So the opt-in option is the agency elects to offer pre-65 retiree health insurance coverage under the local government insurance plan to all eligible active employees and retirees. The limited opt-out coverage with continued coverage for current retirees, the agency elects to opt out to offering pre-65 retiree health insurance coverage and retiree vision insurance, if applicable, under the local government insurance plan to active employees, but continue to offer retiree health coverage and retiree vision to current retirees who meet the eligibility criteria outlined in the plan document. Then there's the option, of course, to opt out, which I don't think is on the table for consideration, but just in case, the agency does not offer the benefits to retirees, and the option to opt out is permanent, and the agency will not be eligible to offer retire health or vision coverage under the state plan at a future date. So those are the options.
Can I just make sure I heard right? This is all pre-65.
Correct.
The current or the whatever, but everything was mentioned as pre-65.
Right. This is all
nothing post-65.
That's right.
Okay,
right.
Thank you. I'm sorry. Go ahead.
So retirement after the agency joins, there is a whole criteria of eligibility, and it's in our plan document, and we'll get into that in just a bit. Okay, so for local government, 10 years a local gov credible service with Rutherford County, less than 30 years with the agency, must be age 55. And just a reminder, this eligibility criteria is for local gov. There's a whole nother set for local education that we'll get into. 1 to 3 years of continuous coverage on the plan. We'll talk about what that looks like if it's a new agency joining the plan. For instance, if Rutherford County came on, what that looks like, that 1 to 3 years of continuous coverage and how that may change. TCRS retirees, your date of retirement must be on or before the active insurance terminates. And then your dental and vision options are up there as well. You must receive a check from TCRS, and then on the vision piece, must be enrolled in the retiree group health plan.
A question. On this, on what you just said, was that moving to it or once you're there?
Yes, that's the eligibility requirements after an agency joins the plan.
After you're there, okay.
Okay, some important reminders, especially the highlighted portion, but I mentioned this earlier about opting out. We cannot reverse that option. However, if you do the limited opt-in, agencies can change their election to a full opt-out option in the future. And then a retiree cannot combine their service with the agency with any other service to meet the eligibility criteria. And then, of course, there's another call out on the limited opt and opt out portion. Okay, so Tennessee plan, this is for your post 65 retiree. Key points here. There are also eligibility requirements for the Tennessee plan that we can walk through as well. But here's some key points for post 65 people who are looking to take advantage of the Tennessee plan. There's no pharmacy benefits. I think everyone knows that's kind of the piece there that's under consideration is the pharmacy benefits. Rutherford County uses the Cigna OAP network, and it has limited out-of-network benefits. The Tennessee plan doesn't operate on networks. Both of the plans are secondary to Medicare. And then the Rutherford County plan calculates a coinsurance of the covered amount and then reduces the benefit by the amount paid by Medicare. It's typically 80%. And then the Tennessee plan supplements the claims approved under Medicare A and B and will not cover any charges in excess of the Medicare approved amounts. So Tennessee plan eligibility, hired by TCRS, qualified agency before July 1, 2015. Retiree must be enrolled in Medicare. Retiree must receive TCRS check. And then in order to cover a spouse, retiree must be enrolled in the plan. So switching gears and talking about local education, and we'll open it up at the end for questions. But your pre-65, going back to that, so think about it in two groups, right? You have your pre-65 and post, and then you have your local education rules versus local government. So local education, group health, any retired employee or dependent under 65 can enroll in the plan if they were hired prior to July 1, 2015. And if they were in the agency's group medical plan the month before joining the state plan. And then after an agency joins, employees who retire after must meet our eligibility requirements. And I don't know, yeah, well, no, they're not listed in here, but we can get into that. Let's see. Pre-65 retiree coverage, some of the key points here for local ed. They have the same benefit offerings, of course, share the same risk pool, have the same premium. The state subsidizes the premium for retired teachers who meet the plan's eligibility criteria, but it's based on years of service and has different groups for 30 plus years, 20 to 29, and then less than 20 years. There is no state subsidy for retired support staff. And then, of course, the LEA can add premium contribution on top of what the state contributes. And then the LEA can offer a separate retiree benefit to those pre-65 who are not eligible. So if they were hired after the 2015 cutoff, then there is nothing that we regulate about a separate benefit. So eligibility for post-65 retirees on the Tennessee plan, first hired by TCRS before July 1, 2015, must be enrolled in Medicare Part A, must receive a monthly TCRS benefit payment, and in order to cover a spouse, the retiree must be enrolled on the plan. So getting into a couple of the things, I know we just talked about retirement, but I do want to go back a little bit and cover some of the active questions first, and then we can get into, say, retirement for the end because it is so different. So a couple of the things we got ahead of time were questions about our MOU, our Memorandum of Understanding. Is it strictly enforced? And it is. If the agency decides to come onto the plan, you'll be locked in for 24 months. There's also a 24-month waiting period if you decide to leave the plan before you can rejoin. The plans for LGA and LEA are the same, but rates are different. We talked about that. Eligibility requirements for retirees are different, and then the employee definition is different. The rates are the total premiums. They do not factor any contributions made by the agency. And then all plans must be offered to all employees, and they'll have the choice of all plans. As far as how much the agency itself contributes towards the premiums, we don't regulate that. That's up to the county to decide. And then as far as if we bring on Rutherford County, whether we bring on the school system and the government or either or, Benefits Administration is not going to have to hire any additional staff to field the difference of what will be added to our plan. The Rutherford County hire date is used for eligibility purposes. The open enrollment period for employees is in 4 weeks in October. We haven't set the dates yet for the upcoming year, but we communicate that as soon as it's available. Participating agencies in the health insurance plan cannot offer, subsidize, or incentivize enrollment of individuals eligible for a state-sponsored group insurance program into any health plan, health insurance policy, or medical expenses plan other than what we offer on the state. There was a question about special enrollments. There is a special enrollment provision. There's qualifying events that allow enrollment of the event if it results in loss and coverage under another plan, meaning the group health plan or health insurance coverage, including any individual insurance policy that covers any person, will be eligible under death of a spouse or ex-spouse, divorce, legal separation, loss of eligibility but does not include a loss due to failure to pay premiums or termination of coverage, and then termination of spouses or ex-spouses employment, employer's discontinuation of a contribution to the spouses, ex-spouses, or dependents insurance coverage, spouse maintaining coverage that has reached their lifetime maximum, or loss of TennCare other than non-payment of premium. ACA eligible employees should be entered into our system as the same as any other full-time employee. It's the agency's responsibility to track the ACA eligibility. The agency should terminate the employee in our system once they are no longer eligible under the ACA Act. There was a question about the spousal rate increase. Not sure if you guys were able to view the insurance committee meeting where this was covered in detail, but basically the gist of it was Aon, our actuary, the same as you guys use in Rutherford County, recommended we right-size the premiums to get the employees plus spouse line a little more in line with other premium options, and instead of a one-time rate increase, it was proposed for us to spread this over 3 years, the rate increase. But of course we evaluate it every year, so it could change or be revised. The surcharge for larger networks, we did talk about that. There were some questions about what percentage of employees are enrolled in employee only versus employee spouse, employee children, and family. For local education, employee only is 40%, employee plus spouse is 8%, employee plus children is 10%, and then the family plan is 18%, with 22% of them waiving coverage. Local gov, employee only is 54%, employee plus spouse is 6%, employee plus children is 7%, and family is 6.9%, with 25% of them waiving coverage. As far as the plan options, so PPO versus HSA and what the most popular plan is, local ed, we serve 111,000 members, and of that group, 64% are on the Premier PPO. That's the most popular plan. 19% is on standard, 14% on limited, and 4% on the HSA plan. Local gov, of the 26,000, 39% are on Premier, 17% are on the standard plan, 38% are on limited, and 5% are on the HSA plan. It was asked if there are surviving family member benefits on our plan. If you die while actively employed, your covered dependents will be offered continuation of whatever state health, dental, vision insurance they have on the date of the death. The runout claims are handled when a new agency joins the plan. They're responsible for all claims incurred prior to the date of coming onto the plan. For example, let's say Rutherford County joins the plan effective 1/1/2023. Rutherford County would be responsible for payment of all claims incurred prior to 1/1/2023. Rutherford County would also retain reserves to cover the runout claims. The last questions we had were regarding retirement, so I do want to pause there and see if you guys had any questions around active, and we'll save the retirement for the end, but anything on active or plans or comparisons, we'll be happy to take those.
All right, Ms. Lisa.
Yeah. You went very fast, so I hope we can get a copy of your answers.
Sure.
But I was trying to hear what you said about if the active employee dies while in service and there's a spouse and children on that plan, what is their benefit if the employee dies?
For dependents, I don't think I mentioned dependents, did I? I don't think so.
I think you said dependents.
The spouse and dependents, but you didn't really give a
say
time
spouses,
frame.
so I didn't know what you said. I thought I heard you say dependents could stay on the plan.
But you didn't give a time frame.
Not a time frame or a
6 month, 12 month, 18 month, or
issue.
So how it works with dependents, let's see. So your covered dependents do not have to be the pension beneficiaries, but if either you or your designated pension beneficiary elected to take a lump sum pension payout, this will result in your surviving dependents losing the right to continue the retiree health insurance coverage, even if other eligibility criteria are met. Let's see. Okay, your covered dependents get 6 months of health coverage at no cost.
Dependents, but maybe spouses if they stay on, if they get the TCRS benefit? Is that what you said? Something about the payout on TCRS. I missed that. As long as they get the spousal benefit from TCRS, then perhaps that spouse could stay on. Okay.
I think all I said was, I think if you are a member of the TCRS system, election of a monthly pension benefit is one of the required criteria to continue insurance for your covered dependents if you die. Is that what you're talking about?
I guess that's what I was thinking. If I was interpreting what you were saying is what Commissioner Allen said, is if the active employees on TCRS and the husband, spouse is the beneficiary, they get that they would then get a TCRS payment, then they could stay on the
Are they considered
health,
in the 6 month, or
as long as they were getting that?
Hi, this is, I'm Teresa Jones with Benefits Administration. I'm the Director of Health Plan Policy. So beyond the 6 months free coverage, surviving dependents could remain on if they meet the qualifications to continue in the retiree coverage. If they don't, then they would be offered COBRA.
So they're off. What makes them eligible to stay on TCRS?
Well, if they're eligible for a TCRS pension, if they're entitled to a survivor's pension.
Survivor spouse, or for some reason they might have said the child is the survivor
Yes.
Of the, that's what, okay. So if this, that's what I was saying. If the spouse is on the survivor benefit of TCRS and they get the pension, they can stay on. But if they don't, they're gone in 6 months.
If they, yes, if they would not qualify for that pension, then that's part of the criteria for continuing coverage. So if they don't qualify to receive that, then they could be offered COBRA.
Okay. But that's limited. That's not forever. Right.
Are there any other questions? I've got a couple, but I'll let y'all. Okay, yes, Ms. Melissa?
Would that also apply to the retirees? So for instance, if an employee retired and was on the retiree benefit, whether it be the pre-65 or the post-65, and the retiree actually passes away but had a covered spouse or child on the plan, would they be allowed to continue the coverage? We're talking about the medical coverage.
So that does also apply to retirees. If a retiree passes away and they have dependents covered on the plan at the time that they pass, then those dependents could continue coverage if they meet the criteria. They get the 6 months free, and then after that they could continue if they meet the criteria of being eligible for the pension. You know, when a retiree, retirees may or may not designate their survivors to receive the pension. That would be one of the criteria.
All right. Is there any other questions on that? I've got a couple, and actually, for just a little statement for the insurance committee, we've not been privy to some of the information that you shared, that you had shared with BOE, and if at all possible, I would like for us as a committee to get some of these numbers or the information about the education part, or I say the BOE comparison, so that we can make a true comparison of our total group. And our total group right now is all County General Highway and the BOE together. So, and we appreciate the time that you've took in making those presentations, but some of us, and me being one of them, wasn't able and wasn't privy to get into those meetings that you have spoke to and spoke about several times, and we appreciate that time. But I got a couple of questions myself. You keep talking about that y'all have a unique plan document. You may have not used that word, but we have here at the county a true plan document that we can critique, add to, take away, and we've had it for all my time here and being able to do that. So this plan that you have presented, does it, and I know you can't get it narrowed totally down, but does it cover pretty much all of the items that we cover in the manner we cover? And if it doesn't, how much of our true plan document today that Rutherford County has does this state plan offer and cover? So that's one of them. And then the next one, when you get to the plans and the networks, the narrow and the broad, and the Cigna and the blue, when it all comes down to it and you have those prices listed, what are the claims paid at once you've met those deductibles that you showed there, whether it was $1,000, $3,000? We either pay 80-20 once a deductible is met, or 90-10. The plans that you offered and presented with these dollars amounts today to us, do they show that it's 80-20 and 90-10 once our employees, BOE, County General, or Highway, have met their deductible?
So we do have a plan document. Do you want to talk about that and what it consists of?
Sure. So we do have actually more than one plan document. We have a plan document for the state plan. We also have a separate plan document for the local education plan and a separate plan document for the local government plan. There are a lot of similarities between the local education and the local government, but as Jessica said earlier, there's some differences. You know, for one thing, the employee definition is going to be different, that kind of thing. But just because there are separate risk pools, we've got those separate plan documents. The plan documents do contain benefit grids that detail the schedule of benefits, like you're talking about the 90-10, the 80-20, for the different plan options. And then it would just depend on whether or not an employee chooses Premier, Standard, Limited, or the CDHP.
All right, any other questions?
I had one question. On the employee spouse rate increase over the next 3 years, I know you said you would revisit it every year, but what was proposed in the insurance meeting, the increase over that 3 years?
I can check for that if you want.
We can pull the exact rate. The overall average aggregate increase for all levels for local government was 4.4% in 2022. Over the last few years, we typically see an average of 3%. For local education, it's around 2.5%, but 3 out of the last 8 years have had no increase, and that's on all levels. We'll get the exact rate for, did I not send it in the email? But we'll get the exact rate for that employee plus spouse line that was proposed.
The reason why I'm asking is, you know, and I've looked at it months ago and a lot of information. Somewhere I got, it was either 48 to 52% increase over the next 3 years. And the reason why I'm asking is because right now, because Rutherford County, if you have a spouse that has a insurance plan furnished by their employer that, you know, meets ACA guidelines, then we exclude spouses. But if we go to the state plan, then we could look for those employees to come onto that plan because you don't exclude it. So that would be a pretty good increase over the next 3 years.
So we don't exclude spouses, but the county could decide to exclude spouses if they chose to do so. That would be a county decision. You have that option, but the spouse coverage is there and it's available if you want to offer it.
Anybody with any other questions? Yes, Ms. Allen.
Excuse me. My first couple of questions, probably Ed, you can answer them. I'll skip to my other ones. Okay, can you go over the limited opt-in again, Jessica? The pre-65, it sounded like, because a lot of what we're discussing, and a lot of what this hinges on is the impact it's going to have on the retirees. So, and I'll fold this into that question, which is, I thought I heard you say that your plan restricts additional benefits, additional products that we could offer our employees, that you want us to be inside of that bubble, right? That state of Tennessee bubble. So my question to you is, what are your thoughts on the Cigna Advantage plan that you heard previously, and it sounded like that limited opt-in option left the door open for us, where we could let some go into the state, some go into that Cigna plan, but we left our foot in the door so that if we needed to come in, we could, and we didn't just opt out entirely on the front end. So I just want to make sure we're having a conversation about that limited opt-in, and could we do some kind of a hybrid and utilize that Cigna plan. And of course, I know all this hinges on enrollment and numbers. I get all that, but I just want to know, just from a policy standpoint, what your thoughts are.
Okay, I have a couple thoughts, and then I am going to let Angie speak. She is on the line regarding retirement specifically. But one thing, back to Ed's call out on the spousal increase, I just pulled some numbers quickly. We will get the official rate that was proposed by the insurance committee. But for instance, this year versus last year, it's about $100 difference is what we increased the rate. So it was like on the Premier plan it went from $1,200 to $1,335. On the standard, it went from $1,100 to $1,200. And then on the limited plan, it went from $1,068 to $1,143. That's local education rates. So you can see it was about $100 difference from year over year. However, we will get the actual rate that was proposed for the next few years and get that information to you guys. Now, as far as the Medicare Advantage,
just quick point. When we're talking about premiums, just so folks understand, when we're throwing these numbers for premiums, that's total premium. Obviously,
that's right.
I just want folks to realize when we're throwing those kind of numbers that, that's both employer and employee share, total.
That's right. All the premiums that we've shared today is total premium. That does not take into account what Rutherford County is contributing towards the premium. Yes, that's a good call out. Thank you. So the Medicare Advantage plan that was proposed for the post-65 folks, even if you were to come on to the state plan, like for your active employees, the post-65, the Tennessee plan is kind of separate from what we offer as far as active and pre-65. So we don't actually, so if you wanted to do both, if you wanted to come on and offer the coverage for your pre-65 and your active through the state and still wanted to take advantage of that Cigna Medicare Advantage plan for your post-65, that is completely fine. I think that answers part of it. The limited opt-out, I believe, let's get Angie's perspective. I think that would kind of fall into the same line. So Angie, the question is if they do the limited opt-out, if they would still be able to offer that Cigna Medicare Advantage plan to the post-65 retirees.
Good afternoon, everybody.
Yes, we can hear you. Thank you.
Okay. Yeah, as Jessica stated, retiree pre-65 I'll have you think about the pre-65. Medicare eligible retiree. Banana. Means your agency is saying, yes, who are going to retire in the future. Folks,
Yeah, the part where I always get tripped up on that is when we have to start making the distinction on the pre-65 and post-65. In my brain, I just want to think active and retired, and I know it creates a lot of subtleties in slicing and dicing that, so I'm going to have to digest that answer, and I'll let you know if it answered my question or not. These questions were for you, Ed. So based on what I saw when they presented to the Board of Education, it looked like their network of clinics was very large. And so one of my two questions to you about the clinics is, will they even be needed? You know, we've been talking about whether or not we, can keep them if we want to keep them. I know one of the pieces of negative feedback that I've heard from employees is they're like, if I'm going to have to pay a copay, why don't I just go to somewhere more convenient or go to my, one of the appeals to them was not paying when they had to go to the clinics. So I'm just curious, are we going to continue to need them? My second part of that is, I know we utilize them a lot for like the biometric screening. Does that whole part of our program go away? Because we've done that in the past to promote wellness and to also offer a discount on insurance premiums. So does that piece go away? Have you thought through those things?
I think that piece would go away also because you're not required to get your points, stuff like that. That would be correct. As far as the clinics are concerned, I have met with them just recently trying to look at other options, but I don't see that it's viable to leave all three open, but some type of maybe occupational health within maybe one clinic, drug screening, things like that, but that's very preliminary at this point. I don't see, as what Lisa says, I don't know how we fund them unless you're going to tack on an additional amount, to the rate, the state rate, and what the share is going to be of the employee and the share is going to be of the county. So I just find it very difficult that we can continue to keep them because it eliminates our source of revenue or into the clinics to pay for them.
Well, I guess in my mind, I want to keep the eye on the prize, and the eye on the prize is not to operate clinics. The eye on the prize is to manage healthcare costs. And so that was one of the things in having those clinics, was to keep the costs low, try to offer, an opportunity for the employees to have quicker, easier access, to care. So that's the goal. It wasn't, in my mind anyway, but I do understand the occupational piece that you're talking about, because we're a large employer. We're going to run a lot of people through, drug testing, things like that. So that may be something we want to continue to talk about. So two things I just had comments on. One is some of the slides, Jessica, in your presentation were not in our presentation on the SharePoint. So I think, Mary, when they provide all the data, if we can have that current presentation so we can go back and look at it, that'd be great. And then another thing that I think would just help the layperson, including myself, to see how these dollars flow is that if you could take, let's just say, a $10,000 medical bill and apply the same expenses. You spent, you were in the hospital and this much of your bill was hospital. This much of your bill was radiology. This is anesthesia, whatever. However you want to lay it out. If you could take some fixed number like that, whether it's 5,000, 10,000, something, so we could see, as an employee, you've got an example you can lay down in front of them and say, if you incur $5,000 in medical bills, and this is just an average example, this is how the dollars are going to shake out. This is how much is going to fall to deductible or copay or coverage, and this is what your premium would be. If we could just make it that elemental, I think it would help us all understand, sort of, at least I know for me, where to go from here.
Yes, and I think too, when you see that chart that we've mentioned before that has our 4 plans side by side comparison, it shows you if you make a primary visit, it's this much. If you do this, it's this much. At the very bottom of that, it has pharmacy benefits, and it also has your out-of-pocket maxes, your deductible line by line compared, plan by plan, side by side, and you can see all that. So I will include that too. I'll feed that into the presentation. There was a little bit of confusion today. We originally thought we were just presenting the local gov plans. That's why the slides were kind of added last minute from the presentation we gave at the board on Tuesday. So once I compile all of that together, I'll send that over to Ed. But I mean, you guys have both presentations right now on the screen there, but I'll compile it all, and I'll include that grid, because I think a lot of the questions too have been around exactly what am I going to pay if I make a visit on this plan and I'm on a state plan, what that's going to be. And then at the bottom of this grid, and it makes it very easy to digest the information, it has a line by line deductible and then out-of-pocket max for each line, employee only, employee plus children, employee plus spouse, for each of our 4 plans.
So I know about the grid. I know exactly what you're talking about, but I want you to take that grid and apply that to just a number, right? And see how do those numbers shake out, because it's very difficult for somebody to go through and say, if this, then that, if this, then that, and for them to try to add it up and figure it out, right? So I want you to do that for us and say, okay, if you choose this plan, this is how a claim is paid. If you choose this plan, this is how a claim is paid. That way all the dollars are laid out, and you can, I know it's going to change, and I know there's a million subtleties to this, but I just think if there's some way to see an example of kind of that equation, like imagine an EOB. That's what I'm thinking. If you had a sample EOB of a $10,000 medical bill, and you chose one of these 4 plans, depending on which plan you chose, what's my EOB going to look like? What's my part going to be? I think that would help us understand how to apply that grid, because it can, I had years and years in managed care. It can get overwhelming, and it's really hard to drill down and to also turn around and then explain to an employee, this is how it's going to be. This is what, I want them to at least help understand how we're going about making this decision. And like I said, just getting as elemental as we can so we can see it.
One of the things that I'd like to point out is we do on our website have summaries of benefits and coverage. So we've got those for all of the different plan options, the PPO, the standard, the Premier, the standard, the limited, and the local CDHP. And part of those summaries have examples. So it has cost example for someone who's having a baby, someone who has diabetes, someone who has a fracture. So those detail, it starts off with a cost, and then it does show what the deductibles are, what the co-payments are, yes, what the co-insurance is. So on our website, down at the bottom of the page, there is an important section, and the summaries of benefit coverage links are there.
If you could even just drop those samples into all the other stuff you're spoon feeding us, I'd love it if you could spoon feed us those examples.
Sonia, do you have a question, hon?
Unfortunately for him, I probably have a couple. I went to the Board of Ed meeting, and I went to this one also, so I'm trying to compile all of them at one time so I don't ask duplicate questions, but I'm just curious, there's 95 counties in the state. Do you know about how many counties participate in this plan?
For local ed or local gov?
We'll say local gov since we're looking at it from that viewpoint right now.
I don't know that we have it broken down by county. We can get you that information. We serve 390 local government agencies, but of course some governments are kind of broken down. The 911 is its own entity, so we have the 911 and the local gov, but it's the same county. But then some counties, they're all local gov employees. We have some housing authorities that overlap with certain counties too. And we can get you the list of all the agencies if you want to see that, but it's 390 agencies across the state.
Okay, so that would include like local utilities and municipalities.
That's
390 right. Is all inclusive of everything, municipalities, counties.
That's right.
Utilities, the whole 9 yards, so, okay.
Community care
and nursing homes, okay.
A quasi-government, yeah.
So to Commissioner Allen's question about the screenings and the med points and the biometrics, does the state require their participants to participate in any screenings, and are there any like penalties, like if you smoke or if you have a BMI difference? Is that something that y'all look at as well in your plans, or is that only for state employees and not participating employers? Does that make sense?
That is just for state employees.
Okay.
Yeah.
All right. You mentioned when you were looking at the premiums and you were breaking out by plans, you had the HSA and you had the copay and the deductible. I know in the meeting on Tuesday night? On Tuesday night, the lady that was speaking said that it was based on actuarial assumptions, how you determined whether to put us in limited or standard or premier. Are y'all following me so far? But she mentioned that she didn't have the county's plans to do the study as that she was only making if I understood her right, she was only making those assumptions based on your plan and then comparing to ours, but not the actuarial study to both. So I was wondering, when I looked at your plan versus ours, the premiums and the coverages, it looked like we should have been in the standard, which is a lower premium than the one that you did the comparison to. So I was curious as why.
I'll take that. We did actually have the plan documents of the current county that we sent to our actuary, Aon, the same people that you guys use for your actuary, and they did the comparison on the premiums, the rates, the coverage, the value of your current county plans versus ours. Again, it's slightly different because our plan is unique. However, when you're assessing an actuarial value, that's about the best you can come up with to determine the value of the plans. What we did was compared your deductible plan to our premier plan, because that's our most robust plan. We compared our standard plan, to your point, to the copay plan, because that's the most similar. Again, they don't align perfectly, but they're the closest ones for comparison purposes. However, the actuarial value assigned to the plan has nothing to do with how we compared it. We just did that on our end to show you guys, like, here's the value of the plan regardless. The standard plan has a value of State standard plan has an actuarial value of 87.2% regardless of, it's not in relative to comparison to anything. We're just saying, hey, this is most closely aligned with your county copay plan, but that's based on the plan documents that were provided to us.
But based on the savings that was hopeful that this would cause, you're having to use those assumptions for our plan in the comparison in order to get your savings, right? Because you're using who's enrolled in each of those plans to determine what savings would be incurred if they were enrolled in the state plan, right?
So none of that took into account into that actuarial value, the enrollees. That is not a part of it. However, yes, if we're calculating savings, what Rutherford County would save, all we know to go off is who is currently enrolled in the plan versus ours, yes.
So you mentioned on the pharmacy that you do the rebates and you put the rebates back in to help offset and you keep the 10%. What then happens when your reserves are used up? Does that then, you're using that 10% reserve to pay for larger claims. If the reserve is used up, what then happens?
We don't ever let the reserve go below 10%, correct?
I think
we'll verify, but we do not let it fall below that 10%. And if there's any stipulations on that or whatever, we can find out. But that's our maintenance base level, and we don't let it fall below that.
That's just a standard
right
line. So you mentioned a couple of extra benefits that come along a part of it. One of them was the agency benefits coordinator, the EAP, some of those other things. Are those costs covered within our participation in the plan based on the premiums, or is that an additional cost? Like, would the county have to pay an additional cost for the EAP? Would they have to fund the agency benefits coordinator that they have on site? How does that work?
So it's those are two separate kind of things. Most of the EAP services are included. However, there's some things like we mentioned virtual visits that you do have a copay if you're on a copay plan or a portion. Most of the services, and if there are specific things, we can say yes or no, but like the Sanvello app is free, Take Charge at Work is free, being a part of the discounts is free to the members. All of those work-life services where they can just pick up the phone and call and ask about food and nutrition, daycare, camps, all that is free. There is no, or it's worked into like the premium that's already set. There's no additional charge for those services.
To the county or to the employee. That's just added into the premiums already.
That's right. They're available to everyone at no additional charge.
So what about the agency benefits?
So the ABC is, the Rutherford County would assign an ABC. And then they would coordinate with our team, and there's no additional charge for the coordination of that, but whoever is assigned the ABC would receive all of that communication and all of those emails and conference calls and videos and all that. And then we rely pretty heavily on the ABC. The size of Rutherford County would probably require two.
primary and a backup.
Primary and a backup. And those would be the main points of contact for us to communicate all of the information changes, anything like that. Additional training, we do webinars, all of those types of things.
So if the county and the Board of Ed went, would we need one for the Board of Ed and one for the county, so we'd have 4 ABCs? Is that what you're saying?
Definitely have 2 for local ed. The county is, how many employees? Over 1,000?
Yeah, 1,400, 1,500.
That require 2?
Yeah, the county, there would usually be a primary ABC and a backup ABC for each agency.
So that would be 4 additional employees that the county would incur that cost in order to coordinate the plans with the state.
Often what occurs is this would not be an additional employee, but it would be somebody that's already in your system, like someone maybe in the HR office, and then they would have those ABC duties part of their job.
So it would be offset. When it comes to open enrollment time, because I don't want to say, we're not small, we're big, but we're not so big, I guess is what I'm trying to say. And I know that our insurance department becomes basically a concierge service. We have lots of employees who, and Mary can attest to this, she's their concierge at the highway department, that meets one-on-one. Would that be the duties of the agency benefits coordinator during that time, or do y'all offer those services? Because there's a lot of employees that will have questions, and I'm sure that they have those in other agencies that you deal with too. So is that something that the state handles, or is that something that's handled at the county level?
In the MOU, the duties for things like that fall under the ABC technically in the documents. However, we have an onboarding team that works with the agency to onboard and help enroll the employees, and will come out and work with the ABC on putting the applications into Edison and getting the employees enrolled. And what we're learning is there is an opportunity for education in some cases, to where, you know, an agency has an ABC who can't answer all the questions and all of that. So we're happy to partner together and just do the right thing for the members. And I personally have been out to agencies, and we just kind of work on a case-by-case basis. So if you wanted to host a session, because you have a ton of employees, and so maybe it looks like an employee, you know, they come in person to an auditorium, and we address the group at a whole and answer any questions in that forum and have a couple sessions there. We're happy to take part in that. We do have our call center where employees can call and get that one-on-one specific, like, here's my situation, and ask any questions. We have, the call center is 50 plus employees that are ready and available to take one-on-one calls. And then again, you'll be assigned an onboarding, outreach, and education specialist. We have a team of 3 and plus an administrator, and I kind of go back and forth on that team as well, that will be assigned specifically to the agency to come and help and be in person for enrollment purposes and things like that. But on an everyday basis, or even just as people are learning about the plan or have questions about the plan, we're happy to help and do the right thing for the members, whether that is, you know, a virtual session that we record and send over, or maybe they watch some of our, we have a plethora of information for new employees coming on or onboarding or learning about our plans, and maybe it's just a Q&A session. So we're just navigating that with the agency specifically, and whatever needs they have, we're able to meet them where they are in the process. Some of them, I was just in Arlington, and they came in with their packets ready to go. They knew what plan. They just had a couple extra questions about, you know, they knew what plan they were getting. They just wanted to know, you know, they had some questions about Blue Cross versus Cigna, or they wanted to look up and see if their doctor was in network. So really at the end of the day, we're just here to do the right thing. In the MOU specifically, it does, you know, kind of fall on the ABC to field some of that, but we do have a team that comes in and helps with the enrollment process, and we will do what it takes to make sure that, you know, the employees are educated and can make the best decision.
Well, to your point, when you were talking about the Blue Cross Blue Shield and the Cigna, and when you were talking about the rates earlier, I thought I heard you say that the rates for the employees, so let's just say they're going with an HSA plan, okay? And you've got a Blue Cross Blue Shield, or you've got the Cigna for that. And you said the employee's premium would be the same regardless of which, I'm going to call it vendor they go with, but the premiums sometimes are different. So how do you do that?
The premiums vary based on the plan and then the network. So if they choose a narrow or a broad network, that's where you see the variance.
But you're saying Blue Cross and Blue Shield and Cigna have the same exact rate. If it was the deductible, I mean not deductible, the HSA for open access, you're saying their premiums are exactly the same?
If they, yes, it varies based on the network, not the carrier.
Okay.
Got any more questions, Ms. Sonia? Okay. Well, okay, go ahead, Ms. Lisa.
Okay, I've got 2. Do y'all require an active enrollment or passive? Meaning, do you make sure, does every employee have to go in and select every year, or can they say, I like what I got, I don't have to do anything?
So employees who don't want to make any changes don't have to take any action during annual enrollment.
Okay, so the passive, you do, okay. All right, the second one, if we have an EA that came from a county that was with the state plan, and they moved to Rutherford County 2 years ago, so we're past the 7/115. Are they allowed retiree benefits or not? The distinction is that they came to Rutherford County after 7/115, but they came from a organization that was in the state plan. So how do you view that?
Angie, can you hear us?
I could only hear part of the question. Can you repeat it?
Yes, I just wanted to make sure you could hear me. So the question is regarding local gov and an employee who started with Rutherford County local gov after 2015, but was hired on with the state prior to 2015. Would their service combine for retirement benefits, correct? Okay.
Well, I'm going to assume we're talking about retirement insurance benefits, not monetary pension.
That's correct.
Benefits, those are two different things. So a government employee can literally not combine service with any other entity, period. So, education service cannot be combined with Rutherford County local government service. So one thing to bear in mind on the local government 5 group health plan, no criteria of the date of hire being prior to July 1st, 2015 for local government health. The criteria there is that the agency, in this Rutherford County local government, decides to opt in, offering the coverage. Should Rutherford County local government do that, then does the employee have a minimum of 10 years of service with Rutherford County local government only? We won't look at combining Rutherford County local ed. We can't combine state. No other agency service, period, combined for a local government employee when we're looking at pre-65 group health eligibility. So do they have at least 10 years? That equates out to a minimum of 120 months of service. If we're looking at 10 years of service as our minimum, years immediately preceding termination of employment and retirement with the Tennessee Consolidated Retirement System on or before the date their active terminates. I know that was a long-winded answer, but so in short, for a local government employee who is retiring, we do not combine or look at any other service, period, other than with the actual local government entity itself.
Thank you, Angie.
Can I ask a quick question to that to make sure I understood it right? If we have a Rutherford County employee who started in, we'll just say my office, and then she decided she wanted to go and be a secretary at one of the schools, okay? So, and that's, I want to make sure. So she was 5 years with me and then moved, and then she's done 15 or 20 with the school. But she could not combine my 5 years of working in my highway department and her 15, 20, whatever she has at BOE. To be able to retire, she would have to, she or he would have to be 10 years, at least 55, 3 years on it, within the plan, within either, I know we're one big plan, but within either our Board of Education group or our county general highway. It will not, because we do have people that go education to county general and vice versa. So please help me and tell me I heard that wrong, but I don't think I did. It's you're all or none in one department, or meet the 10 years at least before you can retire and have any pre-65 benefits.
So that is a little complicated, because if the person went from local gov to a local ed agency, the local ed combining services requirements are different. So I'm going to have Angie speak on the local ed. It's different. So if in your example, if the lady ends up on the local education plan, her combining service requirements are different. So Angie, so you're correct in and of the fact of local gov. It has to be 10 years with Rutherford County, cannot be BOE to combine for that 10-year requirement. But can you tell us the local ed combining service regulations?
Sure. So the example you provided would heavily depend on a lot of specific details about that employee. If your employee had, 5 years of service in government and then moved Board of Education and had a date of hire prior to July 1st, 2015 with either a participating local education agency, the state, or a higher education agency, then we could look at that employee under the lens of eligibility as a local education retiree versus a local government. It still remains the fact that we cannot combine local government service with any other service. So in this example, we would look at that employee and say, number one, do they have the date of hire prior to July 1st, 2015 with a participating local ed, state, or higher education agency? So do they have a minimum 10 years of combined participating local education, state, or higher education service? Have the, minimum immediately preceding termination of employment. If we're looking at, at least 10 but less than 20, we're looking at 3 years of coverage. 20 or more years, it's one continuous year. And do they meet the date of retirement criteria with the Tennessee Consolidated Retirement System? So when you have employees that do have a mixture when they're moving between county employment and Board of Education employment, it does get muddy for folks, because that service may count for the monetary pension benefit. All of it may count for the monetary pension benefit, consolidated retirement system, but we may not be able to, well, in the case of, we can't combine local gov with anything else, but there are folks, sometimes we need to have with a participating local ed. Do they have state, higher ed? Do they meet the date of hire? Black or white right answer. And their, types of service they had. Not even other local GUPs. So if they had they can't combine that with Rutherford County local GUP. Only local GUP service from that local government. But local education is a little different.
Okay,
Thank you.
Thank you. All right, Ms. Sonia?
So I'm 99% certain I know the answer, but I just want to make sure. So let's say the local education went to the state and you had employees who were not, let's see, I'm trying to make sure I say this right. Maybe they worked for another educator somewhere else. Well, they still wouldn't have met our criteria. Wait a minute. Let me scratch that question because I already answered it in my own head. If somebody worked for the Board of Ed, there's two different things at the Board of Ed. Let me first say that. So I noticed on your site that there is the education, the teacher side, and then there's support employees. Who is considered support, and does that go under, for the purpose of this conversation, a Board of Ed can't be combined with the local government or anything else. For purposes of this, is a Board of Ed support person considered a Board of Ed person for the purpose of the pre-65 retirement eligibility?
Okay, Angie, the question is, as far as support staff goes, what qualifies as a support staff who's eligible for the pre-65 retiree?
Are they considered a Board of Ed? Yeah. Or is it the criteria is the same July 1, 2015 or before? And are they, so the reason I'm asking this is I'm saying I want to make sure that when we're talking about Board of Ed that everybody understands that there's two different plans. There's one for the teachers, but then there's also premiums for support staff as it relates to pre-65 retirees. So what makes up a support staff person at local education? What does that include?
Okay, so I think there's two parts of this question. One is the definition of a support staff employee, and we can pull that and give that to you guys. But then, Angie, they're asking for support staff, the eligibility requirements for retirement, just the premiums vary, right, based on teachers and support staff, but the eligibility requirements are the same?
So we consolidated retirement system when we're reviewing service and what will count and what will not count. So it will, if you're reporting the employee as somebody that works for the Board of Education in a support staff role, that's how their service will be coded with the Tennessee Consolidated Retirement System. The eligibility criteria for a local education support staff employee to continue pre-65 group health, it's the same eligibility criteria for a teacher to continue pre-65 group health. So the criteria is not different in the local education plan for a teacher versus support staff. You do see a difference in the under TCA state law. The state, cannot contribute towards a support staff employee's insurance premium, where there is a provision in state law for the state to contribute to a certified teacher's premium. So that's where you're seeing the difference in the two premium grids. So no difference in eligibility criteria, but there is a difference in
So if somebody worked as a support staff person at the Board of Ed, and then they came over to County General, say they worked at the Board of Ed for 8 years, and then they came over to County General and they worked for us for 5, they're not going to be able to combine that, even though there's a support staff. So I'm just saying, let's say their payroll person at the Board of Ed comes to the county to be a payroll person, they're going to have to meet the eligibility. And if they had worked there 10 years, but they were not here in time to meet that eligibility, or vice versa, say they worked at the county for 10 years and then went there for 2, they're not going to be able to reach the July 1, 2015 hire date, even though they may have the years of service. That's what, I'm understanding that right? Because you can't combine the two.
For local gov, yes. For local education, it's different.
Right.
It varies a little bit on combining the service, which she just mentioned earlier. It gets a little convoluted with the specifics. You have a different set of, it depends on if that person was hired prior to the July cutoff, the July 1, 2015 cutoff. But if they were coming to local gov, to your first example, and only had say they worked 25 years and only had 5 years with local gov, they would not meet the threshold.
So somebody who worked for the state, we're just going to say the state of Tennessee, they worked for the state of Tennessee for 10 years, then they went to the county for a couple of years, and then they went to the Board of Ed. They're not going to have, you can't combine those services, even if they were hired with the state July 1, 2000, okay, and then they come work for the county, and then they go to work at the Board of Ed. It's not, that's different, right?
No. So with local education, Angie, you might have to help me a little bit here, but your example was the person worked for the state and then they left and then went to the county and then went to local ed and ended up retiring from local ed. They would then have to meet the local ed requirements. Go ahead, Angie.
When they're considering retirement. And it's for these types of varied questions because there's so many different variables that can around and they change agencies and et cetera. All the examples that you're presenting have to look at the individual's specific. There could be situations where that person, they might criteria under the local education. Then they immediately move to a local government role, and there's, possibilities that there's no lapse in coverage. If they met all the other criteria under local ed, they could fall back on that when they retire. But apologize, I can't give you specific yes, no, black, white answers when we're talking about changing local ed to local gov and throwing state in. It's very, very specific to the individual. I can recommend is that should absolutely contact the Benefits Administration Service Center when they're thinking about retirement. And we go through each person's service, their history, etc., and help determine, if and when they would be eligible.
I think, too, the big call out for clarification purposes is the local gov does not combine. The local ed has potential to combine. There's a million different scenarios. As long as, right, Angie, state, higher ed, and local ed has the potential, but it's not as strict as like the local gov plan where it says absolutely does not combine, correct?
Yeah, you can definitely walk away from this afternoon cannot be combined, period. Any other service. That's, I can definitely.
And I only asked that question because we have a lot of employees that do that. That was the only reason for it.
Every single local ed in the state. Education agency, state, or a
Okay, thank you. And then we had the definition pulled up for employee. Okay, so just, I know you asked about support staff specifically, but just so everyone is on the same page, an employee should mean a teacher as defined in TCA Code 834-101, an interim teacher whose salary is based on the local school system schedule, a regular full-time employee not defined above who is regularly scheduled to work at least 30 hours per week in a non-seasonal, non-temporary position, a non-certified employee, which would encompass your support staff, who has completed 12 months of employment with a local education agency that participates in the plan and works a minimum of 25 hours per week. Let's see, school board members or all other individuals cited in the state statute approved as an exception by the local education insurance committee or as defined as full-time employees for health insurance purposes by federal law. Employees not eligible to participate in the plan are as follows: any employee who does not meet the definitions outlined above, or substitute teachers and other individuals in positions classified as temporary appointments or performing services on a contract basis unless they otherwise meet the definition of an eligible employee.
Thank you. Is there any other questions? Yes, Ms. Melissa.
And I apologize, I don't want to beat a dead horse, but I want to make sure that I understand the July 1st hire date, July 1st, 2015 hire date, whether it be a Board of Ed employee or a local government employee. If I work 10 years for either group, for local government or the schools, and then I leave because maybe I had a baby and I needed to take a year off. I'm not on leave of absence, I resigned for a year. And I resigned in 2014, I had 10 years of experience. I come back to employment after July 1st, 2015. Is any of my 10 years going to count toward my eligibility for retiree insurance benefits?
Okay, so
what hire date are you going to look at?
Yes. One thing to note with local government, that July 1st, 2015 does not apply. That's local education. So two separate things. But Angie, she's asking in both if she were to take a leave of, or like resign and then come back. So I think for local gov, if you came back and still met the 10-year threshold, you would be fine regardless because that 2015 does not apply to local gov. But Angie, for local education, if she were to quit and then get rehired after 2015, she's asking eligibility status.
Well, it would depend on, she cash out the service when she left originally. Not be able to use that data. participating local ed, state, or higher ed.
Thank you.
All right, are there any other questions? Yes, Ms. Allen.
On the spouse issue, I'm anticipating not just spouses will come back, but entire families will come back, because when we made the change and spouses left, you had some families where it was cost prohibitive for them to have coverage under two separate plans. So is there any way for you to look at the amount of folks we had covered before that policy was implemented so that we could maybe try to predict how many new families would come back under the policy?
So yes, if you guys send us the numbers of how many people you had enrolled, yes, we can look at it and, you know, try to figure out the cost savings based on an estimate of how many people you had originally. All we have is what was the most recent sent to us without that included. But yeah, if you guys send us those numbers, then yeah.
Well, I think one of the things I asked you earlier about the percentages that you had with spouses on your plans, and then that would give us a better idea of, you know, you would think that the county would mirror that same percentage that the state has if they went to the state. That's how I would.
So we pulled the meeting minutes from that insurance committee meeting, and what was stated and shared, I don't know where that percentage came from exactly, but the final benefit recommendation was to gradually increase the premium. There was no percentage given for the employee plus spouse tier in all plans to actual experience with this recommendation being phased over a 3-year period. And then of course, they covered the average aggregate increase, and that is just, you know, an average per plan, which I shared earlier for local ed was 2.5%, and then the local gov plan was 4.4%.
Yeah, this was a couple of months ago, but I believe it was a video that I watched of the meeting itself. Maybe it was just discussion, and that's the number that was talked about. That's why I was asking, because I want to make sure correct information is giving out. I'm not saying that it was, I'm just saying from memory, a couple of months ago, I think I saw a video that said that. It's actually the video of the insurance meeting, it's state insurance meeting itself.
And we'll confirm.
I believe, again, this is coming from memory, I believe it may have been May 2021.
Yes, it was covered in the May 27th meeting, and that's the minutes we pulled up. And but we'll go back and just verify. Okay. I mean, it may have just been discussed, but yes, if there is an actual like increased percentage, we'll share that with you guys, of course, if it was specific to that tier.
And then the only other thing I had was, you know, the Board of Education can make this decision completely independent of this body. So have we talked to Cigna or Mercer or anybody to go ahead and try to look at what our premiums would look like in the event that we lose Board of Education as part of this covered group?
Yes, and that's later on, if everybody stays with us, or we can. You got a county commission meeting at 6 o'clock.
I'm here till 6 o'clock, so I've got nowhere to go. I can show you where the coffee is.
All right, are there any other questions? All right, and I know this is a lot of information, and we had said today would be informational and for us to try to look at and try to have our heads wrapped around something to do an even more in-depth discussion come January. So with that being said, we still have the Mercer presentation on our agenda. If everybody could bear with us, let's take about a 5-minute break, stretch our legs, and come back and ask Mercer to hit the high points, please. You've provided a plan or some sheets here, And I don't think we were going to make any decisions with that today, but it's information, that way we'll have it and give us about a 5-minute break. Thank y'all for being here, and please don't go away. As we're all getting back to our seats, do y'all need to come up here, or can you do the podium?
I think I can just do the podium. Okay. I know we're starting to lose people, but everybody's still.
Okay. All right. Well, we'll start this meeting back off here with a Mercer presentation. And
we'll let everybody have a seat.
All right. You can go ahead and get started, please, sir.
All right. Does everybody have in front of you a large piece of paper that has kind of plan designs at the top? We're going to put it on the screen. It's also on the iPads, and it's going to be a colorful little tab on the iPads. So from the Mercer perspective, our goal today was just thank you, the state. Thank you. A lot of information presented by the state, a lot of information presented by Cigna. We were hoping to kind of be able to wrap it all up. So we're going to do that quickly. What we've gathered here is there's a lot of questions. It has a lot to do with rates, and there's a lot of kind of the extra stuff. So I know Sonia's asked questions, Melissa's asked, everybody's asked questions on retirees, what's included in the plans. So at the top are the high-level plan design summaries that we've heard asked several times. So if you look at the top, the first 2 plans are Rutherford County's current plans. The next 4 are the state. So you've got the Premier, Standard, Limited, and High Deductible. And those, again, Commissioner Allen, they do not give you if I have a $10,000 claim, but it does show you the deductible, out-of-pocket, copay, pharmacy copay. Shows you the detailed plan design of all the plans for the Rutherford County currently and the state. Below that in blue, if everybody sees a blue box, that is going to be the current Rutherford County rates versus the current 2022 rates for those state plans as well. So if you'll see for our OAP or copay plan, today it's $820.35, right? That's the employee-only rate. For the local plus, it's $787. If you go to the right, $499 for the high deductible OAP network, $479 for the high deductible local plus. And then again, you can see how that compares to the Cigna OAP and Blue Cross P. So that's what they call their broad network. And then you can see how it compares to the Cigna Local Plus or Blue Cross S for the state, which is what they called on their presentation narrow network. There is, if you look at the math, so if you also looked on the far left box, you'll see the enrollment. The reason why we're giving this today is we finally have 2022 enrollment. So which plan did everybody pick? So we have about 50% in the high deductible and about 50% in the copay. We ended up with 25% in the local plus, so you can see how the enrollment breaks down. The blue box is Board of Education. The orange box is county government, and the green box is a combined. So what we wanted to show was the rates today versus the local education, which is the blue box, the rates today versus the local government, which was, I believe they said, level 2 county government. And you'll see they vary quite a bit. So for the county government, if you want to look, that's kind of what we were talking about today. If you look at the orange box, if every single person that enrolled in the copay plan today chose I'm looking at the first one, which would be the state premier, which, as I said, what they said is one of their most selected. If every single person enrolled in the copay plan chose the state premier, and every single person enrolling in the high deductible today with us chose their HSA plan, it would actually cost the government $721,000. And you can go to the right. Again, we're making some assumptions if everybody enrolls in the Premier. Now it's if everybody enrolls in the Standard, it's $81,000. If everybody enrolls in the Limited, it's, it could save up to $2 million, depending on what plans people enroll in. If you look at the blue box, those numbers are a little different. The Board of Education rates from the state are lower. So when you compare that to our current rates, depending on what plan you enroll in, it could be anywhere from a $5 to a $7 or $8 million savings. So it's a lot of money. What we want to make sure we understand or leave here today is, though, we've pointed out there are several things embedded in our rates that are not necessarily in the state rate. So that's what, when we're doing a budget, we want to make sure we're including everything. So one of those would be clinics, right? Our rates that we charge, this budget rate includes around, is it $2.5 million now, Ed? 2.1. About $2.1 million in clinic fees or clinic costs. Okay? So if we wanted to keep the clinics, which I believe we heard was an option, that would then be added back to, it would be added on top of the rates. Another one would be HSA funding. So what we wanted to show, because that was a pretty easy one, if you look to the far right, we actually included that. So when you're going rate to rate, it doesn't show you that right now we're spending all total a little over $2 million in just HSA funding. So that's giving employees $500 and families or employee plus anybody $1,000. Again, those are not in the state rates. That would need to be added above and beyond those rates. That was the purpose of this spreadsheet, was to show that you have plan design comparisons, you have the plan rates, and then you have some things that we need to think about that would either need to be added back in or taken away depending on how we wanted to compare the plans. Okay? But there are also a million other questions. So I'm going to pause there. You have this. We can look at this, for as long as you want. We can talk about it more in the next meeting. But are there any other questions in addition to rates that we want to maybe try to address right now before we leave?
I have one.
Go ahead.
On your assumption, you're making the assumption, like we just heard that our copay plan is very similar to the standard, to the PPO.
Correct.
Of the state.
Correct.
And in your calculation, you're saying if everyone went
from the copay,
Premier, which is once again a richer plan.
Now the standard's right there in the middle. It'd be $7 million if everybody went to the standard.
Okay, so it's a seven. If we went apples to apples, I mean, we could do what ifs all day long.
Yeah.
The $7 million is that's with if everyone.
If everybody in the copay plan today went to the state standard plan, correct?
Right.
And everybody that's in the HSA today went to the state HSA, right? HSA to HSA, copay to standard. You can go copay to Premier, copay to standard, copay to limited, depending on what assumption you want to make. It's honestly probably going to be a mix of that. You may have some HSA people move to a copay, which then would change things. But
I don't think, and I agree.
Yeah,
I mean, but there's going to be some migration, obviously.
Absolutely.
If you offer employees benefits, I mean, we have a plan here from the state that has an offered and limited PPO that we don't offer right now.
Correct.
So the assumption would be, if you offer benefits that currently the employee doesn't have and they could afford, then they would migrate.
Correct.
When some of these savings would be, I don't want to say lost, it would be utilized
that's
to
fair.
provide our employees better insurance and options. I mean, I don't think that's a loss.
Yeah, I mean, again, our rates include, if you go to the state, the clinics would be a big one, right? Now it's either considered a loss or not. I don't know. That's for the committee to decide, but that is $2.1 million that if we wanted to keep the clinics, that would need to be adjusted here. If we didn't want to keep the clinics, we could absolutely lower our rates by $2.1 million too, right? So again, that's again for the committee to decide. Our rates have a lot of items embedded in them. Let's put it this way, and I've heard Lisa say this before. Our rate is supposed to be a fully functioning rate, meaning everything that we take in and budget for pays for everything associated with benefits. We just wanted to make sure that everything we're paying associated with benefits is kind of compared to both plans, just so we all know. We're not saying there's a right or wrong decision. We just want to make sure we know what we're gaining or losing depending on what we decide.
So what you said is that if we wanted to compare on the HSA, just on the HSA, either we reduce our premium down $50 a month, assuming that we're not going to fund, or you deducted off the state, because I guess still the board could still choose to say fund it, but they would have to add $50 a month to that cost.
And that's what we have actually done that here. So if you actually look to the right, we went ahead and did that just because we knew that was a good example. So this $7 million does actually include funding almost $2 million of the HSA. You look to the far right. Again, that's what that was our assumption here, is that the board or the government would choose to still fund for an HSA, and that would just be $7 million. What we're saying is there's now even more costs that have been brought up today. Clinics is a big one. That's $2.1 million. Spouses is a big one. So when we did the analysis, when spouses came off the plan several years ago, we recognized 7 to 8% savings for the Rutherford County plan. When we ran the analysis now and we assumed a 10% addition of the spouses. So we assumed that the employee-only tier would drop by 10% and about 10% would be added to employee plus spouse tier. and we said the employee plus child tier would drop by 10% and add 10% to the family tier, so 10%, it raised those rates 5%. So 5% to the budget for every 10% of spouse addition is how we were looking at the spouses. Now, again, I think the state said something around maybe we could choose whether to allow spouses or not. Was that? So I don't know about that. But, it sounds like that might not even be an option. But if you wanted to include spouses, we would say you probably need to add 5% to the rates here for an assumption of migration back.
Because we looked at that when we did this before. We said, hey, we can either do the same thing. We can charge more to the spouses, or we can just exclude the spouses. And the decision was, let's just exclude the spouses unless they have other coverage. Sounds like the state plan went the other way with it. And that's why, I guess, based on those numbers, even though it may be a 2 or 3 overall increase, that $100 to the spouse was more like 8 or 9%. So it sounds like the state plan is deciding to increase more to the spouses maybe over the course of the next few years. I don't know, but that number earlier was more like an 8 or 10%, which is just another way to make that change. I mean, but that would be something to consider. If we think more spouses are going to come on, that will erode a little bit of the savings.
But you could shift, that's a full premium. The board may decide we're going to, just like in our retirees, they may say, okay, for that tier, there's more cost to the employee to cover that.
Mm-hmm. Yeah, this does not take into account, just like the state said, contributions at all, right? This is just billed premium rates. So we do have discretion over contributions, HSA funding. We do have some discretion over that. These are just the rates billed by the state. Good point.
Okay, Ms. Allen.
Okay, so the question I was asking earlier is the one that I still feel like needs to be answered, and that is, what will the rates look like if Rutherford County's pool is now much, much smaller? Because we're not going to have the same rates today or then that we have today. So do we know what impact that would be on that smaller pool? And then I hadn't even thought about the effect of spouses. So is there some way to try to predict then, in order to make our risk pool larger? Does it help us to bring spouses back, thinking that that's going to bring some people back, or does that hurt you because you're going to increase utilization, right? So
yeah, I would say it would be the second. Bringing spouses back would not increase the risk pool enough to offset the cost. Okay, but we worked with our actuaries and with Cigna's. We do think the Rutherford County, so the orange box rates would go up 8% if the Board of Education leaves. So you'd see an 8% increase in those rates.
All right, are there any other questions? All right, this is good information. Ed, do we need to do anything with this? This will help make decisions, or more information come January? More information come January, and we appreciate your time, and sorry to cut you short, but we do appreciate it, and I'm like Miss Allen, if we can see what it would look like for county general, for the better term for everybody else, the county general, what would it look like if BOE did leave? What would it look like? Those would be some good numbers to help us look at. Is there any other business? Yes, Ms. Allen.
I just have one other thing I want to add. So, the other thing, not only do I want to see the effect on the rates, like she just talked about, but I also want you to rethink plan design. Because if you were always writing a much smaller group, you might have made different recommendations than you made to the size that we've always been. So I would just say start with a blank slate and come back to us and say, if you're at a point where you're needing to overhaul your benefits to maximize that value for your dollar for the employees that are left and to not go backwards on coverage, this is what we would recommend. That's what I would like to see too.
Okay. All right, thank you. Now, I've got one item under other business before we adjourn, and I'm not really sure how many folks know, but today will be Miss Melissa Griffey's last day on the sitting up here as the insurance. She's worked with the county insurance for well over 11 years. Seems like forever, doesn't it, hon? But she will be leaving. She is going to a different department in the county, and I'll just tell you, I'm finally getting me some help. Me and Miss Diane's gonna have some help, I'll just tell you. So we are very much looking forward to Melissa coming and bringing some extra information for our guys and things like that. And I know she'll be missed in insurance, but I do want to say thank you for all that you have done for all of the county employees and even the retirees, because if some of my guys come or the retirees, I'm like, call Melissa. But we appreciate her, and I know Ed and the girls will miss her, but I get to. No, she's not that far away. So, but just to say thank you, and you're very much appreciated for all that you've done and getting us to this point with the whole benefit system and everything. So thanks, Melissa. So, being no other business, reminder, our next insurance meeting is going to be January the 27th of 2022. So thank you for your attention today, and I'll call the meeting adjourned.